trauma program, including improved detection of brain injuries through consistent use of post-traumatic amnesia assessments. So those are just a few of the things I wanted to highlight. As I said, we know that it's a work in progress. We're trying to get better at demonstrating our impact, what we achieve. We're pretty pleased with this year's annual report. We think it shows a good year, and we welcome your questions.
Excellent, thank you. We have two questions, Andrew, then Aisha, and then Ricardo.
Thank you. If I may, Mr. Chair, just a primary and 3 or 4 subs. Thank you for all you do. The questions I'm going to ask you are going to go to a number of organisations, because we've got claims from the Mental Health Minister in particular that we're seeing increased treatment access, increased training, more community workers, more frontline workers, that people have got somewhere to go. I'm wanting to know why there isn't a national mental health safety dashboard in the 300 indicators that you have provided in your report.
As you know, our work in terms of the mental health and addiction quality improvement program has been taken back into Health New Zealand. So our main window into what's happening in the mental health area is through the requirement now to always report and review seclusion, and then through our more general work. But I'll ask Richard Hamlin, because he'll be a bit more aware of what, if any, work's been done in terms of your actual dashboard question. If you introduce yourself, Richard.
So I'm Richard Hamlin, Director of Health Quality Intelligence at the Commission. So we've not really advanced a mental health dashboard ourselves, largely because others were doing it, and particularly the Mental Health and Wellbeing Commission did a lot of work about their own assessment frameworks, and there are other things we can do that we have to do, and we were happy to let them take the lead on that. There are things that are emerging, though, one of which is a collaboration with the Commission around a patient experience survey for those who are in mental health or have experienced mental health services. We also have produced data from the primary care survey, which we put inside an atlas showing mental health, the experience of mental health care amongst that cohort of patients. So we have done things, but we've allowed the Mental Health and Wellbeing Commission, which has primacy, to take the lead here.
Thank you. And in your letter of expectation or statement of intent, it says that you must report on areas of increased risk. We have seen from crisis performance that it's been deteriorating. There's abandoned calls, longer waits, Māori overrepresentation in police cells, crisis assessments and so on. Why have you never issued a quality alert on crisis service safety?
Do we get that data?
It's not data we don't actually have access to, so our alerts tend to be those that we automatically have.
Why don't you get access to it? I mean, when I read the paperwork, it looks like there is an umbrella requirement, and mental health seems to be completely missing from the data that you are providing insights into.
I wouldn't say completely missing, but it's certainly less of a priority, largely because of the existence of the Mental Health and Wellbeing Commission, but it's a fair challenge to raise.
We've also got the same regarding ED mental health harm in ED wait times in emergency departments. Have you done any analysis into that?
Not specifically on mental health, but on ED wait times more generally. We've done some work which we have shared with.
And finally,
so just following on that line of questioning, a lot of the answers do seem to be that it's the Mental Health and Wellbeing Commission is leading this. How do you two work together on something?
Well, a good example would actually be the specific thing we're doing now on a patient experience survey for mental health patients, or for mental health cohort of people who use mental health services. There it's a matter of early engagement with them about the design, involving them in our design processes, sharing the data. We provide them with data to support their annual reports and so forth. So there's a flow of communication between us, and we can work together. We do.
So just
and I can just add that we also meet at a leadership level too quite regularly with the chair of the board and also the chief executive. And I might say just a slight declaration here, both Sunny and I've just recently been appointed to the Mental Health Commission board. So both Sunny and I are on that board. So there are opportunities for greater cohesion across the two.
You've got one more.
One more. So what do you see as your kind of responsibility in this partnership?
to support, to provide support where our expertise is there, and to work with them where they have expertise that we can use in things that are very clearly our responsibility, like the patient experience program.
So we would also see some, I think, mental health at the sharp end through the SAC1 and SAC2 adverse event reporting as well. So I guess we're going to see increasingly patient experience, which we can bring into the mix, working with the Commission. And at the other end, we see the adverse event reporting, which obviously we work straight back through Health New Zealand providers on in particular.
Ingrid.
Thank you. You did mention seclusion, and there's a level of granularity in some of your other markers, such as falls, infections, and medication harm. But when it comes to seclusion, we don't see anything around inpatient seclusion, inpatient restraint, bed occupancy pressure, overcrowding risk, or sentinel events in acute mental health units. So why are you not including that level of detail in your mental health National Safety Marker Program?
Well, this was designed with the system about the things that were most useful to them. I'm not actually sure there's a huge amount more detail than we'd give in the mental health seclusion than you would find in our other quality and safety markers. Those were very much designed with one outcome measure and a series of process measures. For the mental health seclusion program, the process measures were quite disparate because people were doing different things in different places to get things down. And there was a single measure or a diverse way of reporting a single measure as an outcome, which is pretty common to what we would do.
Given everything you've said and where you say the accountabilities lie, would it be a fair assessment to say that your picture of the mental health system, based on the data or lack of data that you have and the lack of analysis, is probably very thin, and that this lies elsewhere?
I think we see part of it. And I think it comes back to, in fact, how we work with a lot of things. We get different pieces of information in different parts of the system, and it's about being able to kind of do well at putting it together. But I think you're right. We do see parts of it. We don't see the completeness. And I think there is opportunity to do more in that area, particularly working more closely with the Mental Health Commission.
Not many parts, though, compared to other.
Aisha.
Thanks, Mr. Chair. And noting that we've had many opportunities to talk, I just want to go a bit deeper into some of the areas in the annual report.
Thanks.
I'd like to ask you some questions about Figure 2, please, which looks like a really interesting effort to try and quantify the value of your work. Can you please explain how these savings are calculated? And what I'm trying to understand is this a real readout on what's happening now, or an estimate projecting benefits based on the evidence about the interventions that you use?
I'm going to ask Richard, because he's much better than I am in explaining things like DALYs and how we come to these calculations.
Okay, so there's two elements here. The first is the avoided cost of harm. The second is the value of avoided disability adjusted life years lost. You're comfortable with the concept. So on the avoided cost of harm, when we started any of these programs designed to change behavior in the system so that you got better outcomes, and there was always a clear evidential link between them, we also looked for the best evidence we could find on an estimate of cost. So this is all from the peer-reviewed literature. We will take an estimate of cost. We have applied that throughout. We have not adjusted for inflation. The way that we use this is the way that we have measured our outcomes is we take the specific outcome harm, we measured it over a baseline period prior to the introduction of the program. In classic quality improvement style, we then monitored what happened to that outcome as we saw the change in process. Once we had seen a statistically significant reduction measured by statistical process control methods, we then reset to a new level of current harm. The difference between those two was used to estimate, or to calculate actually, a reduction in harm based on what would have occurred had the same initial level of harm been
Okay,
applied.
you
to
get the
the
prize
patients.
for the best answer at annual review. Thank you. I mean, that's great, and it's good to see an effort to calculate the from a small number of your programs the benefit. Our party is very interested in the opportunities to prevent more harm in the health system because of this. You know, not only do people get out of hospital well, but there's also these opportunities to save money and bed nights through that you've outlined here. What are the other opportunities to do this that you currently don't have programs on?
If I might suggest, one of the most interesting ones to me is pressure injury, which has increased particularly both in and outside of hospital, particularly in the years following the COVID experience. What is quite interesting is about 10 years ago, some early work was undertaken between ourselves, ACC, the then district health boards and others around what would be necessary to address what the issue then. Because I mean, obviously occur bad things when they do. My sense is this is a much more complex one to address because there's a lot more going on. In some ways, actually, rather like the seclusion. And it needs more people to come to the party to do things. I mean, what's actually quite interesting about most of the ones we report here, there was pretty clear cause and effect. I think with some of these other ones, like pressure injuries, it's more there. But it does seem to me what we are seeing there is a definite opportunity.
It's also been a persistent problem. So we're seeing it again and again in each set of data that comes through, that it's not kind of shifting. That's correct, isn't it, Richard?
Yeah, in fact, it as I say, it had worsened and it is stuck at a kind of new normal level, probably 20 to 30% higher than it was prior.
The other area that we've seen, and this is highlighted through some existing programs, but has come up more recently and certainly struck us in terms of some of the insights reporting is, and bearing in mind the ageing population, is the care pathways, is the difficulties that are arising, which you can't just put down to the fact that there are more older people and increasingly more older people, but where, you know, older people are more older people are spending longer in hospital, and there aren't those kind of step down. There's not that continuity that we need to be really thinking about between primary care, hospital, aged care, you know, other community supports.
Just two more, Mr. Chair. What are the types of solutions that might be able to be implemented for the pressure sore area? And what I'm trying to, pressure injury, as you put it, is this a matter of simple checklists like you use in some of these other areas, or is this about staffing and resourcing of aged care?
It's more complex than that, isn't it?
Yes to both, and
Yeah.
you know, there are easy access to appropriate mattresses, for example, would be another example. There is probably something about home care as well, not just age residential care and sort of those sorts of things. There's probably something around, I was going to say health literacy, you know, sort of. So I mean, it feels to me this is a very multifactorial approach.
My final one, if I may.
She's got one more.
Thank you for those comments about pressure injuries. Just interested if any other officials want to broaden out that comment to other areas where there might be opportunities over and above pressure injuries. We shouldn't let the opportunity to do good be passed up.
Did you want to say, in terms of mortality review, Diana, is there, I mean, one of the things with mortality review is, you know, we have to prioritise and do what we can, but if we had the opportunity, where would we see it in terms of wiping it?
Don Matheson's my name. I'm the Director of Mortality Reviews. Thanks. There's huge opportunities in mortality reviews. There's between 8,000 and 10,000 preventable deaths every year. Probably the tricky thing for us, though, is which of those does our role in health quality and safety can make a difference. And of course, there's lots of other parts of the sector also focused on reducing those avoidable deaths, from ACC and MSD, and I mean, there's a broad number of factors in it. Where we're focused currently is looking at, as Ray said, perioperative mortality, SUDI, maternal mortality, perinatal and maternal mortality, and avoidable mortality with regard to cardiovascular disease, particularly regarding treatment for cardiovascular
Dr.
disease.
Matheson, could you just repeat those? I got perioperative mortality, cardiovascular, SUDI.
Perinatal, maternal.
Yeah.
Sorry, perinatal and maternal. Yeah.
Perinatal and maternal.
Thank you.
Mm.
And one
So,
thing, oh, sorry. One intervention that I recall from previous maternal and perinatal mortality review reports is improved access to maternal ultrasound. I mean, in terms of a single intervention that we're not doing that could be done that would save some of these prevent some of these avoidable deaths, do you think that's significant and a helpful intervention, or are there others you'd prioritise ahead of that?
Well, from previous reports, we see it as a very helpful intervention, particularly if it reaches those with the greatest need. So it's just two elements to it: is their access, but then making sure that the people with the greatest need actually get access.
One of the reasons for the shift that we've been making in the mortality review space, I know we've talked about this with you before, but is actually designed to try and shift the needle to get some of these recommendations implemented. And so that's why we're quite excited about the perioperative stuff, because it's actually, I mean, it sounds like it's just another group, but it's within Health New Zealand. We're involved. There's a bunch of very senior relevant clinicians who are actually looking at what's happening with the mortality figures there. And we're hoping, we can get some bit more real-time action when we see things and identify them.
And how would you, sorry.
I was just going to say, with regard to ultrasound, the story over the mechanism was that the Mortality Review Committee made it as a recommendation. Subsequent from that, the National Quality Forum took it up. Took maternity and maternal health up as an issue of focus. And so, that was sort of engaging the other sector actors in it.
Excellent. Thank you. Another area of kind of doing no harm or preventable harm is hospital or healthcare associated infections.
Mm-hmm.
So what sort of programs have you been doing? What success have you had in that area?
Well, ask Martin to come and join me, but we've had quite a significant program with various, the hospital-acquired infections, hand washing, hygiene, those kind of things. That program of work was one of the ones that got shifted back to Health New Zealand in June, but we have had some quite significant success with it at the time. Martin is our expert in this area.
So Martin Thomas, Clinical Director at Te Tahi Hahora. As Ray alluded to, the Infection Prevention Control Programme transitioned this year back to Health New Zealand. I assume Meryl mentioned about other opportunities, and one of the things that we were looking to work on if the programme had remained with us was around peripheral IV infections and Staph aureus bacteremia, which is a growing issue. So that would have been one of the other areas that we looked at. Healthcare associated infections, particularly post-operative infections, there is an opportunity to expand the work that we did in that field. We did undertake a point prevalence survey a number of years ago, which identified potential opportunities to expand the healthcare associated infections programme. Most of the healthcare associated infections are usually associated with implants, so peripheral IVs, urinary catheters. So it's looking at areas where you can produce packets and bundles of care to reduce those infections. And we've had success previously with joints, so introducing programs to reduce joint infections, which was very successful. Just looking to expand those areas really.
It's not, I mean, it's not directly related, but it's probably relevant to mention that we have done quite a bit of work and continue to do in the sepsis area. And I was really pleased. Actually, it's good on a board, you're often a little bit removed from what's going on, but I was at a function recently and a senior clinician or senior manager from Southern Cross Healthcare came up to me and said, thank you so much for those tools and for those resources for our staff. You know, they're really helping in terms of early identification and treatment of sepsis. So it's the kind of stuff we produce and people use.
Thank you. Okay. Whatu.
Thank you. Just looking at the sections around enabling the workforce improvers in the survey and leading health quality intelligence. Looking forward in terms of the survey that you've produced, how are you looking at incorporating the patient's experience when it comes to staffing levels, safe staffing levels more broadly, and being able to also try to quantify that in the surveys that you do?
Some of that feedback informs our insights reports that go up to the minister. So everything that we do is informed from those patient surveys. So any opportunities we get through our work to provide information to decision makers and to frontline services, that it informs that. It comes, and so what comes from the patients is used in that as well. And so particularly, you know, some of those insights reports do contain information around staffing levels and people's experience. There's a lot of, we get a lot of feedback, particularly around access to services from people.
Because across the health system, we hear from nurses, allied health, doctors, et cetera, around concerns on safe staffing levels. From the insights you have produced so far, what story does that tell you when it comes to patients being able to access the health system where there are safe staffing levels?
The story that we get from patients is that they still, and I'm looking at Richard, he can correct me if I get it wrong, but we still hear from patients that they're waiting too long. But once they get into the system, we still consistently hear that people receive an amazing standard of care. And, you know, with whatever's happening in terms of the pressures and challenges of staffing, it's clear that the staff themselves go, you know, above and beyond to ensure that people, by and large, get a very good experience.
And finally, so in terms of the programs you've done to improve the competency of workers when it comes to patient safety, which looks really, really good, do you think, though, that there's concerns that the efficacy of those programs may be hindered by the fact that we are seeing in some wards and in some space in the health system, staff not being replaced when they leave, and therefore having less staff being able to carry out the work that you're training them and equipping them to do?
I mean, we keep delivering the programs and they're still available. So, I mean, people will come through as they join up or as they come on board. People will undertake the training where it's available. I'm not quite sure.
So we have heard that, for example, if staff leave in some areas of the health system, they are not being currently replaced. If you have less staff being able to deliver the same amount of work in a shift, for example, do you not think that no matter how much training you give them, things will fall one way or the other and go waywards as a result of lack of safe staffing levels?
It's a bit outside our remit in terms of safe staffing levels. I mean, if we see issues arising, whatever the cause relating to quality and safety, they'll come through the various avenues, including the adverse event reporting. And then we would expect that the subsequent investigations by Health New Zealand or whoever the provider is would then highlight whatever might have contributed to that event. And if staffing is an issue, then that would be where it would be picked up.
Thank you.
Okay. We've got a few questions. We've got Cam, Ingrid, Jenny, Carlos, Asha.
Thank you. This is far from my area, but I'm asking about some of these work plan reporting tables that are in the annual report. Do you feel that the targets that are being fully achieved and delivered on are specific enough, or I'm reading them and it's coordinate the scoping phase with the wider health sector to develop a strategy that defines the patient safety. I mean, there's not.
Yes.
Do you think that's quantifiable enough?
This is what we struggle with. As I said to you, when you're not directly, like what we do and then the outcome, there's a whole lot of stuff that happens in between. And so it's an ongoing challenge. And, I've been on the board for a few years now. We're constantly grappling with how we can get better and clearer about how we measure what we do and how we report on it. And we don't just report what we've done, but what we've achieved. So we've got a really good opportunity coming up because our statement of intent is due for renewal, including these measures and the way in which our reporting, the reporting measures that we use. And so we're meeting in February to talk about what our new strategic priorities are, what it looks like and what we're how we're going to measure it. And we will be continuing to try. I agree with you that, they're really hard to kind of get your head around sometimes. And so we want to get clearer, and we're working towards that, but noting the difficulties when you're a few steps back from what happens. Yeah.
Okay, well, that's probably enough.
Does that answer your
Yeah,
question?
it's a good answer.
Yeah.
Thank you.
Okay, Ingrid.
Thank you. Just going back to mental health. You have a mandate which includes highlighting emerging risks across services. We know that mental health is in crisis, particularly for youth. There's a survey out currently by the mental health group in Auckland. We see increasing crisis need, worsening inequities and so on. And we've seen, and we've had in this committee reference to a letter to Minister Ducey from the Health and Safety Disability Commissioner in relation to the tragic suicide of a 13-year-old. I've looked at a number of coroner's reports, and the Mental Health Commission itself has identified the lack of safety guards and rails and tracking of data with the 1737 and other telehealth services. Why are you not monitoring that? And what would it take for your organisation to formally identify these telehealth performance services as a safety issue?
Is it a data gathering?
Is that yeah.
I don't think we got the data on that.
No, yeah. Ingrid, I think there is an issue about avoiding duplication across the two commissions. And so it would be a matter of needing to really clearly think about what is the bit that we can really add value to where we're not duplicating responsibilities or work being done by the commission. And then should we do it or should they do it? So I think you're highlighting an opportunity to do more. But I think that's about as much as I can say at this stage. It sounds like from Richard, we don't actually have the necessarily data, apart from if it pops up in other channels like mortality review or, those sorts
Patient
of
experience.
things. Yeah.
Because we know with
Or
the
adverse
commission,
events.
it's very much dependent on where they see a public interest or a need. Is this something that you will talk about in February when you talk about your strategic plan and the missing data and perhaps oversight for some of these?
We will, because you've put it on my radar.
Thank you.
And just getting back to Aisha's question earlier, the other thing I really did want to highlight that we're thinking about a lot is the commission in its 10 years or whatever so far has been very hospital focused. And we are acutely aware of the need to do more in the primary care space. And so I think you'll see going forward from February and the changes to the SOI and that, we've made it a stretch KPI for Sunny that we want to do more in that primary care and community area as well.
Supplementary, Mr. Chair.
Supplementary.
I understand that sounds like a work in progress, but could you expand on the type of measures you might make?
Well, we're doing some work already, aren't we, in primary care around quality measures?
Yes, so we have been working with GP around their quality dashboard about deriving, and I think a lot of the approaches we've taken for the Atlas, which are quite disease specific or patient group specific, is actually quite a nice way into this, because you can actually think about the whole pathway of a patient's experience of how a patient is treated. A lot of the data which have not been available are what happens inside the GP surgery and that sort of interaction. What we can get a bit at the drugs, a little bit less on the testing and so forth. So one of the things what we are looking to work with them is how can we bring together what we have from the sort of Atlas-y type measures to the sorts of measures that they can derive from GP systems, and then can we put these in more intelligent sort of pathway sets of indicators, and then look at the variation. We have done actually a good example of this way back in the past was around antimicrobial resistance and sort of antibiotic prescribing. Now we actually did a small sort of nudge type experiment where we wrote to all GPs, and this is where you sit on the distribution, this is where you sit for Māori and Pacific as well, because often that was under prescription rather than over prescription. And we did see just simply sending the letters in an appropriate sort of way actually led to a change in antimicrobial practice. So there are things that we could do in those sort of spaces which could pick up on that sort of flow of appropriate treatment.
We're also getting more granular with the patient experience surveys and people's experience of primary care and feeding that back very directly to the practices.
Supplementary.
Yeah.
Can you see a world where I'll exit my GP clinic and provide satisfaction feedback, and that's available to others to see?
Well, we already have the patient experience survey for primary care, which is
In terms of understanding patient satisfaction at a particular clinic so that others can see that.
all right. So that's publication at
Yeah.
GP level. I can see some real problems of that level of granularity and potential perverse effects. I mean, there's 30 years worth of evidence on what is the effect that, how do people respond to quality ratings of services, and it's not necessarily in a consumeristic way. And there are some quite interesting, shall we say, some interesting unexpected effects, and there are some interesting dogs that don't bark in the literature. What you do tend to see is that organisations respond rather than consumers, and I'm happy to share the literature.
I'd love to see that. Thank you.
We have a primary from Jenny Markov.
Thank you. Just, you, at previous times you've been to speak to the committee, we've talked about surgical mesh and some recommendations that you had made, and just really having the opportunity now to give us a catch up on
Where it's at. I'm going to bring Martin up because Martin is actually our representative in this work, so he's up to date with the latest where it's at. Are you able to update the committee,
Yes,
Martin?
Martin Thomas, Clinical Director again.
So could you just push that slightly further? I know
Away or closer?
closer. I was having trouble before, so.
Okay. So there were 4 recommendations that were made for the lifting of the pause on surgical mesh. They were setting up of regional multidisciplinary team meetings, and they have been established within each of the regions. There was the establishment of the registry, which I believe the contract has just been signed with Monash, and that is in the process of being rolled out, and we facilitated that last year in helping that to get the registry across the line. It was establishment of the credentialing, which has occurred, and development of patient resources to enhance informed consent, and those have been completed, and we completed those maybe 6 months ago. So currently it's the rollout of the registry, which is due to happen over the next several months, which would then cause the review of the pause lift to be reviewed.
Supplementary.
Yeah, no, that's fine. That's fine.
On the credentialing, how widespread is credentialing, and are we at a stage where every potential surgeon is credentialed?
No, there have been 4 rounds of credentialing. There's currently a review of the credentialing process that will be led through Health New Zealand, and the credentialing framework, which is the standard against which surgeons are credentialed, is due to be reviewed in the next 3 or 4 months. There are people that are still awaiting credentialing that haven't been credentialed for a number of reasons. Partly, one I think is because of the requirement to set up new credentialing panels and a new credentialing process in the new year, and some of the surgeons have not applied because they found the process onerous, is what we've been reported about.
Yeah, we're well aware the surgeons don't like this thing, but there is a safety issue here. So have you foreshadow that the pause may be lifted? Would it be lifted in a situation where every surgeon performing the surgery would have to be credentialed, or would they get the opportunity to continue to operate without being credentialed?
No,
Resume operating.
They would be required to be credentialed against that standard.
Okay. And this review of the framework, that's not watering down the credentialing standard, is it?
No, the terms of reference have yet to be drawn up, but from my perspective, no, we will not look to be watering that down. There is some discussion as to whether it should be credentialing just of mesh. We're arguing that it should be credentialing that covers the whole of pelvic floor procedures.
And the Health and Disability Commission is in there with us on that too, isn't she?
Yeah, well, we have conversations with HDC regularly about that.
Thank you.
So it's still a work in progress, really.
It is, and it's very slow.
Yeah, yes. So how far, if you were to give it a sort of a number, percentage-wise, how far through the process is it in terms of achieving the recommendations that have been set? So we have sort of a clear picture.
The 4 recommendations for lifting
Yeah.
the pause, I would probably say 80 to 90% there. And that's a discussion around lifting the pause. There's still a decision to be
I have
made.
one more
Yes.
final question, if that's fine. Thank you, Mr. Chair.
Is this a new primary?
Yes.
No, you'll have to wait. So. Carlos.
Thank you, Mr. Chair. My question is on the annual home and community support service experience survey.
Yes.
Obviously, it was launched last year in 2024. Can you highlight to the community what concern have you found in the survey?
Yes, I'll ask Richard to come up because he handles these surveys.
And I would have to consult my notes on the things that were in there. We do a lot of these. Of memory, there were some concerns around time spent with the client, but I would have to sort of revisit the paperwork on that.
We could get you that information if you
So
like.
let me remind you, your report actually highlight the issues is communication, scheduling appointments, and also the service provider doesn't take seriously regarding the complaints by the clients. So I would want to see, obviously you make this survey, you get the findings.
And we feed it
What
back.
action, yes, so what action have you given to the service provider? And do you have any follow-ups?
Well, we undertake this on an annual basis. All of these are reported to the service providers in detail. They have both the data and underpinning reports to show the issues for them, which have comparative data. We don't have a regulatory role in the HCHS sector. So our role here is one of providing information.
And encouraging them to do something about it.
So for my saying, as part of your job is go to give advice and recommendation to the ministry. Have you give that advice and recommendation, or what advice or recommendation have you given to the ministry to consider?
I would have to check exactly what's been done on this one.
But we do update, as a general term, we can come back to you with more specifics, but anything like that is part of our regular reporting to the ministry through our quarterly monitoring that they do of us and what we're doing in terms of feedback.
That's very important. We get the findings. Oh, sorry, Chair. I think it's very important to get the findings and follow up with the issues, not just do the survey for the sake of doing it.
Oh, absolutely. Would you like us to come back with more specifics
That
about
would be
that?
great.
Okay.
Thank you.
Thank you, Chair.
Thank you. Aisha, you're up next, and then Ingrid, then Jenny.
Just wanted to start by saying, I thought the annual report had a good balance of describing your activity across the focus areas that you're working on. So I picked maternity and wanted to go to your website to try and find information on what the measures or reports actually show. And I can't get very far with that. And I wondered if you could tell me how it is that a member of the public would find that safety information or quality information on maternity services in a way that gave them, a layperson, an understanding of what the issues are.
Oh, well, we would hope it's through the website, but from the feedback that you've given us, it's not as easy as it could be. Sunny, did you want to address that?
Yeah, if I can just expand on that. So we recognise that the website needs considerable work to be useful to members of the public, and that's work we're currently undertaking. So some of you are probably aware that website design is actually a really complex thing, and websites have multiple audiences who are looking for information for multiple purposes, and so there's always a balance to be struck, but we do recognise that's a piece of work currently ongoing. We recognise that the issue with it.
Yeah, thank you. And I do note it is some of the data on the website is called an atlas, it's clearly there for quite a high level of detail. But at our last hearing, we had quite a bit of back and forth about the change away from writing particular reports on maternity, and your team outlined that the information would be on the website. And my concern, how do you address the concern that reports are packaged for the public. And now we've got the information is on the website. The last I can find in the maternity LMC registration data is from 2018. But how do we have this in a digestible format for the public so that there can be some understanding of what these quality issues are, absent having proper detailed written reports regularly issued?
I think, as Sunny's indicated, it's a work in progress, but we are looking at lots of different ways to get the information out. So if you look at for instance, the surgical mortality information that we've put out, the team's done quite a good job with an infographic. Now, you do need backup stuff to provide, as we noted at the board, a lot of context around how to understand it and read it. But, looking at things like infographics, at visuals, at other ways of putting things into bite sizes. And, as Sunny has said, there are different audiences. And so we need to think about, the public's need perhaps a little differently from perhaps what providers might need, and make sure we accommodate both.
Do you think it's as accountable, this system of having the information either in a very, very detailed website? Because those reports drove questions from journalists and inquiries and pressure to improve things. And there hasn't been a proper maternity report for 2 years now.
There will still be, you're talking specifically about maternity, there will still be reports for some things. I know, for instance, there's a report coming around disability that's going to be really good in the new year. With Don, did you want to talk about what we're doing with the maternity information? We are actually we're currently analysing the 2022 data, as I understand, if you're talking about mortality review, and there's going to be information released in the new year in 2026.
Yes. Can I add one more to the list I gave you before, which was family violence, which is
Thank you.
Yeah.
In terms of mortality review for maternal mortality, we last reported in the middle of last year in the 16th report. As we speak, we're currently again reviewing maternal deaths. There's a number of years delay, well, not delay, but until the necessary information is about. So we'll be this year, we're reviewing 2022 maternal deaths. And to answer your question, what we're heading for is, as Ray said, is a public-facing information, but also other layers of information that those in the sector might be interested in. And that's what we've developed in the perioperative space, where there's a explorer type tool, so people in the sector can see where the deaths are occurring and where the variation is occurring and take action. And so that's what we want to do across different areas of mortality, to have these different layers for the different audiences. So it's not to move away from detailed reporting, but to have that reporting more up to date, and also more accessible, particularly for the people who can act to address the issues. And that's why in perioperative we've helped establish within Health New Zealand a mechanism so that action's taken. The difficulty we had previously was the reports were very well received by the sector and journalists, as you indicated. However, the impact in terms of reducing mortality was modest in many cases. So we are looking at how do we work in the system to have greater impact, and that means doing things a bit differently.
So that segues really nicely into the June report into femicide, which you have referenced. And femicide is, of course, intentional killing of women. And we can see from your report that in a 5-year period, 25 more Māori women than non-Māori women have been killed. So that's quite specific and important data in the sexual and family violence space. you talk about recommendations, and I guess it's even more difficult when you've got multiple agencies involved. So I note that you don't have markers, that there are no sort of ways of ensuring that aftercare recommendations are taken up, that there are system change monitoring things available. There are obviously data gaps, including equity gaps relating to specific ethnicities. And I go back to, again, your core statement of performance expectation, where you have a very strong emphasis on measuring equity, and yet we don't see public equity measures for mental health, safety or quality. So my question really is, how effective is that report going to be in reducing our horrendous sexual and family violence statistics? And why the focus on something that goes deep and is important, but covers multiple agencies, when we still have this paucity of focus on mental health indicators generally, which include Te Tiriti obligations and which are not present in your reporting?
In terms of impact, it goes back to that challenge around, that was a very good report. It got a lot of public attention, and it certainly, if you're measuring it in terms of raising awareness of the issue, it certainly gets a few ticks there. But it goes back to the problem that we're grappling with, and with all of the mortality review and indeed all of our reports. There's very good data, very good information, pretty good recommendations. We could probably do fewer, and we're trying to get better at that. And then it's the bit about how do we make something actually happen. And that's why we're so much highlighting what's happening with the perioperative stuff, because to actually get in and then, in that case, have an actual working group of people who are taking responsibility, accountability for making some changes to what's been identified is the way we need to go. So it's around, with all of these things, trying to find ways to, however we package it, whether it's a report, whether it's through infographics, whether it's a whole suite of things, it's about then finding ways to get that engagement and to make some change, because ultimately it's the change we want, whatever it is. And we're saying it's a challenge, but we're working on it. And there are some signs of progress in some areas, but not all.
Yeah, and thank you for your answer. You talked about aged care before. In Australia, we saw that there was a separate agency that held governments to account on how they implemented Royal Commission recommendations, which upholds the gravitas and credibility of the Royal Commission. For an organisation like yours, do you have enough legislative teeth or levers to be able to get the outcomes that should be coming from these really good reports and the recommendations that you give? And if in a blue sky world, what would be different so that we can see some change? Because we're getting report after report, particularly in sexual and family violence, the stats get worse, if anything.
I think that that's a decision that's kind of outside of us as to what you want the functions of the Health Quality and Safety Commission to be. That's a government decision.
Yes.
In terms of the levers that we currently have, it is around influencing, leading, punching above our weight as a small entity, and ultimately being able to make recommendations to, give reports to the minister, to agencies like the Ministry of Health and Health New Zealand. If there was a desire to give us more teeth than that, then I think that's a political decision.
Just to supplement that.
Yes.
Thank you for that. Yeah, and noting that the Latin American community has been really welcoming the report you made around this, and we've received feedback on it. Are you doing a subsequent report to track the recommendations that you've outlined in the report on femicide? And if not, how will the public get that level of accountability over the recommendations you've made and the list that have actually been implemented by government?
Yes.
Have you got a follow-up plan?
Yes. So for that report, we're working with the Centre for the Family Violence and Sexual Violence Prevention, which is the multi-agency grouping, because the actions that need to be taken go across government. And we've discussed some of them, including support for people and survivors, etc. And so we will be working with the multi-agencies in terms of how they adapt or how they take up the recommendations.
But we can only influence, we can't force them to do it.
I agree, but are you doing any sort of future work to kind of following the recommendations to track where those are at and to publish that at all? Like, because otherwise these recommendations just go into a void, and I just want to check.
And we have done that with some of our other mortality review reports. We've done subsequent reports. I have to say, though, it's pretty depressing putting out another report some years later that just shows all the things that haven't happened. I'm not saying that's a reason not to do it, but yeah, it's just a comment. But it's
yes.
something we'd look at. Yes.
Yes.
The answer is yes, we're looking
Okay.
at it. Yeah.
Cool.
When you say,
So-
thank you, when you say you're working with other agencies, what does that look like?
There is an established mechanism of government, all of government, on the focus on the issues of family violence. So it means well, we've done a number of presentations to that grouping about the report and its findings, and working with them about what specific recommendations might look like.
So do you work with them on their own performance evaluation metrics to see if you can influence embedding some of your recommendations into how they measure themselves?
Depends on what you're talking about. Are we still talking about the femicide and mortality
Yes,
review
so
report
as an
recommendations?
example.
Some of the experts involved in the work that we do work with them, don't they? Is
Yes,
that the
yeah,
answer?
yes.
So that would be a good outcome to see some of your recommendations end up in their own evaluation frameworks. How
Absolutely.
often does that happen?
I couldn't say.
Yeah,
We have to.
It does happen.
That's good.
We've looked previously at recommendations that work and don't work. Those that are quite specific for a particular agency or a particular actor, and if it aligns with current government policy, there's a number of factors which we can identify would say a recommendation has a fair chance of sticking. And there's also the inverse of that as well. We know when recommendations don't, when there's not alignment or where it's too general or where it's not specific enough. So in this case, that report identified a number of quite specific issues, some of them relating to data, some of them relating to the intersection between family violence and other issues we've discussed today, such as suicide and mortality, other mortality. And so that's those sort of quite specific recommendations are more likely to be taken up by agencies taking a broader view of where they might seeing the evidence around family violence.
Thank you very much. It's very helpful.
Thank you. We have 2 minutes left. So, primary, Jenny Marcroft.
Thank you. We've been talking about mortality quite a bit, so I want to continue that theme in terms of palliative care. We know that currently at the moment there's no specialist palliative care in the far north in hospitals. So is that a piece of work? And obviously with an ageing population, more people are requiring palliative services. Is this something you are looking at, or if you could speak to that at all, please?
So Ray referred earlier to the work that's coming up very soon in the new year on our new SOI and on our new statement of intent.
Right.
Yep. And so one of the lenses I guess we'll be applying to that is the ageing population and what we need to look at newly and or differently in relation to that. And palliative care is part of that. And palliative care obviously is a very broad quite broadly encompassing phrase. So it's not specific to aged care. So I'm not sure, are you asking, is there more
So
you want
I'm
something more
asking-
specifically you want to ask?
So I'm asking, is that going to be a area of focus for your work? Yes, we do have an ageing population. More people are requiring palliative care services. There's less funding available for things, organisations like hospice, but also we've seen that there is a lack of specialists in child palliative. So is this an area that you're going to be focusing on, and when can we hear from you on that in more detail?
So I would say this is the sort of thing that will be considered in the work that we're doing on the statement of intent, because I can't preempt the board.
When we look at, among the multitude of things we could prioritise as a small entity, these are things that will be in the mix in terms of the next few years' work and focus. I mean, the sad thing is that we can't do everything. So we do have to work out which are the bits where we can have the greatest impact. I'm not saying that's not one of them. It's one that we need to consider. And certainly we need to be very aware, I think, of the changing demands on the system with this, big cohort of some of us going through and all going to hit 80 around the same time in a few years.
Thank you. Hey, thank you very much for making yourself available for an hour today. It's greatly
you.
appreciated.
Thank you.
Have a good day. Thank you, team.